All right, good morning everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. Today we're going to go through a PowerPoint presentation put together by Melanie, and I love the graphics on this. And for those of you on Facebook, you can jump onto YouTube live, or we will be reposting this in about a half hour. Okay. So relative to dizziness, we're going to talk about anxiety as an inducing factor. We're also going to talk about how a lot of patients with vestibular syndromes develop basically anxiety in and of itself and or depression. The two disorders are invariably linked, and basically it's something that I think it's important for us to understand how the two may play off of each other. And so going through this, I'm just going to go through a variety of slides. This is discussing PPPD, also being referred to as triple PD. And I'm actually going to start with these articles here. This is out of the Journal of Medicine, and it's a fantastic article in my opinion relative to investigating vestibular causes of anxiety. So what I'm going to do is I'm going to go through vestibular causes of anxiety. What does that mean? It means when someone has something wrong with their inner ear, how that can cause anxiety in and of itself. Then I'm going to loop back and talk about how anxiety can be associated with dizziness. Okay, so in this article, they were out of basically like an ear, nose, and throat practice. They studied a big group of people who had different conditions causing vertigo and dizziness. So just as a generality, benign paroxysmal positional vertigo, many of you may know, it's referred to as ear rocks, where calcium carbonate crystals will dislodge from the inner ear and go to a part of the inner ear where they shouldn't be. Notoriously, people with BPPV will lay down, they'll turn over in bed, and all of a sudden they will have acute vertigo, typically lasting seconds, maybe up to a minute, which then resolves and is followed by a lot of unsteadiness. Now, basically, vestibular migraines, which is designated here as MV or migrainous vertigo, is when individuals typically have light or sound sensitivity. They may have headaches of migraine quality. They may not. They may actually have more of just like a generalized headache and light and sound sensitivity associated with their dizziness, something to watch out for. So that's migrainous vertigo. They can also have true vertigo where the room is spinning around them associated with the migraine. So vestibular migraines is a pretty wide diagnostic subset that is important for any clinician or patient to be aware of, because it can even overlap with the third entity here you see labeled as MD, which is Meniere's disease. Meniere's disease is characterized when people have acute vertigo, room spinning around them, typically for hours, sometimes days. There's lots of times tons of vomiting or lots of vomiting associated with it. Pressure in the ear, ringing in the ear, that all seem to go together, and it can be intermixed with periods of dizziness in between. VN refers to vestibular neuritis, or vestibular neuronitis as it used to be termed. Vestibular neuronitis is when somebody is going along, they're absolutely fine, then all of a sudden they're hit with sudden onset acute vertigo. Some people say this is the most common cause of vertigo. Other people say BPPV is. Nonetheless, in terms of acute vertigo, vestibular neuronitis is common. It's a common reason why people go to the emergency room thinking they're having a stroke. And it typically will resolve on its own over a period of weeks. It's important for vestibular neuritis patients after 5 days to a week to get back to life and try to accommodate their vestibular system, because if they lay in bed, lots of times they will not have a full recovery. So they need to get up and get moving around and things of that nature. So in this article, they're basically looking at, okay, here are these 4 major conditions as causes of vertigo, and what's the incidence of anxiety? And they looked at the female to male preponderance for the different conditions. You can look at that here. And so they were examining all of these factors. Now, this is really interesting, because they also wanted to say, okay, if we're looking at this group of vertigo as causing anxiety, we need to account for certain factors. So here they're accounting for vestibular function. And as you can see, basically BPPV was categorized as having normal vestibular function close to 90% of the time. What does that mean? That means that they may, and good morning to everybody joining too, I just want to comment on that. So the BPPV patients, and for everybody on Facebook, again, I'm doing this live on YouTube. I'll repost to Facebook so you can see the slides. If you want to see the slides, look at them now on YouTube. So BPPV, about 90% of the time, has normal vestibular function. Now, they do have a vestibular problem, meaning they have the crystals dislodged in the ear, causing the person to have vertigo, but the vestibular system itself is not damaged. Now, with migrainous vertigo, they found that about half the time there were signs of vestibular dysfunction or central vestibular dysfunction, whereas in Meniere's disease, they found basically that, oh, excuse me, I misquoted that on migrainous vertigo. It's about half and half. So half the time they have normal vestibular function, about half the time they don't. Now with Meniere's disease, about 25% of the time they have normal vestibular function, 75% of the time they don't, which makes sense. Same thing with vestibular neuritis, it's about 80% of the time they have abnormal vestibular function. But when they then started looking at, SAS basically refers to an anxiety scale, SDS looks at a depression scale, they found that it was really the migrainous vertigo and the Meniere's disease that were most commonly associated with anxiety and depression. And even though vestibular neuritis causes vestibular dysfunction clearly and acute vertigo, it's not as much associated with anxiety or depression. Neither is benign paroxysmal positional vertigo. So it raises the question, okay, all these cause vertigo, particularly vestibular neuritis has vestibular damage. One would think that if there's vestibular damage, that the vestibular damage is somehow causing the anxiety, because the pre-existing thought was that deep in the brain, for all of our YouTubers holding it up high, deep in the brain you have this structure called the insula. You can't even see it's deep in the temporal lobe, way deep in the temporal lobe. It actually, here's your parietal lobe, as you can see it. And deep in the parietal and temporal lobe, down in there is this thing called the insula. And the insula, and the parietal insular vestibular cortex, as it's termed, PIVC, parietal insular vestibular cortex, was thought to be the structure in our brain that basically showed us, you know, where we were relative to our surroundings, and it had a lot of implications in people who had anxiety associated with dizziness or anxiety associated with vestibular disorders. Turns out that maybe that thought wasn't as correct. So the authors surmised that the Meniere's disease and the migrainous vertigo or vestibular migraines were the cause of anxiety, because the person doesn't know when the vertigo is going to hit them. They don't know when they're going to have a bad day. And so that episodic nature to it that's unpredictable, but also rather disabling, they felt was the cause of the anxiety and depression associated with illness. One could say benign paroxysmal positional vertigo has an episodic course as well, but it's not nearly as disabling. Somebody who has vertigo when they roll over in bed certainly may feel dizzy, but the rest of the day, but the majority of people can go on and go through their day relatively unscathed. Whereas if you have a Meniere's attack, or if you have a vestibular migraine, lots of times you're down for the count. Your day is, not going to be what you expect it to be. And again, that brings up my anterior cingulate talk, like I always seem to talk about every day. Expectations versus what we expect, expectations versus what reality is. So for everybody on YouTube, expectations versus reality. This air signal in the anterior cingulate, which has a map of what we think our life should look like, when there is an error, can be a big predictor of anxiety and depression, or a large cause of anxiety and depression, to say it more specifically. So basically, this is just another graph detailing what I was just saying. So yeah, you can look at that in more detail afterwards. Okay, so that's basically comparing what I just talked about. Okay, so going back up, let's now talk about gait and dizziness. I just want to go through this as well, because dizziness affects older individuals a lot. And this article, I think, was out of Practical Neurology. I could be wrong. I think it's out of Practical Neurology. Yeah, I'm pretty sure. And so in this article, I want for everyone on YouTube and for everyone later on Facebook to look at this, but I'm just going to read a statement here. Dizziness interferes with the everyday activities of 30% of persons over the age of 70 and is so severe that it constitutes a reason for consulting a physician. So 30% of people over the age of 70 are suffering with dizziness. That's super common. And when you get into that age demographic, you're lots of times dealing with a multitude of conditions a little different than someone, let's say, who's below the age of 50 or 45. Why? The last article I went through, PPPD, Meniere's disease, migrainous vertigo, vestibular neuritis, are particularly common. They're not unique to that age demographic, but if you're looking at somebody with dizziness, you're more likely to see someone with those conditions in that age demographic. Lots of times diagnosis as a doctor is all about, okay, what age is this person? Is there male or female preponderance? Age is a big predictor of diagnosis. Whereas someone who's over the age of 70, now we have Pandora's box of things that can be wrong. So, someone may have atrial fibrillation. Again, I'm not saying somebody who's young can't have a heart condition causing their dizziness, but the person may have atrial fibrillation. They may have another cardiac condition. They may have 3 blood pressure medications that are causing them to have dizziness. They may have peripheral neuropathy where they have numbness and tingling and burning in their feet, and they've lost sensation in their feet so that they don't know where they're at relative to their surroundings. They may have macular degeneration or cataracts. They may have a vestibular paresis or a vestibulopathy because of diabetes. So think that diabetes can cause cataracts, diabetes can cause vestibulopathy, so lack of basically vestibular sensation, and peripheral neuropathy. So now you're walking around and you've lost your major sensory systems that tell you where you're at relative to your surroundings. So that's called multisensory dizziness. You may have Parkinson's disease. You may have normal pressure hydrocephalus, where there's too much cerebrospinal fluid in your brain, and your brain is basically being compressed. All these factors have to be accounted for in someone with dizziness who's older. And I think this is a really nice graph. The blue are individuals over 80 years of age. The tan, or I guess lime green, are those who are under 40. And so BVF refers to bilateral vestibular failure. BPPV, you can see that here. What was CV? I don't know if I can remember what CV was. Central vertigo, that's right. CV is central vertigo. So bilateral vestibular failure is much more common in the group over 80. So is basically central vertigo. BPPV is a little more common. Unilateral vestibular paresis, a little more common. Now look at this. PPPV refers to phobic postural vertigo, which I'm going to talk about in a second, which is characterized under the category now referred to as PPPD, also referred to as triple PD. So that's way more common in younger individuals. Meniere's disease is a little more common, and vestibular migraines are way more common in younger individuals. So that's kind of cool. Okay, so now we're going to go up to PPPD. All right. Persistent postural-perceptual dizziness, a common characteristic and treatable cause of chronic dizziness. I think this is out of the journal Medicine, if I remember right. Anyways, anybody who wants these articles, I can go through them. And again, good morning to everyone who's watching, and we will repost this. Okay, so PPPD, what is it? PPPD is the newer diagnosis for what used to be referred to as phobic postural vertigo and chronic subjective dizziness and psychophysiological dizziness. What that means are individuals who lots of times have dizziness when they're upright, when they're standing, when they're moving, or when there's visual motion, meaning they're in a car and there's cars going past them, they feel super dizzy. I wish I would have drawn the Venn diagram, but I'll just discuss it because it's important, because I've done a lot of talks on dizziness in the last 3 months. And it's important to distinguish, let's say, between PPPD and MDDS and vestibular migraines and something like Meniere's disease. So individuals who are at rest and they feel like they're rocking or bobbing, who have had recent travel on a plane, a boat, or a car ride, or sometimes they can be spontaneous, and that motion improves with motion, or excuse me, that motion sensitivity or that feeling of rocking or bobbing improves with motion, meaning they get in a car and it goes away. They start walking and it goes away. That's where you're talking more like vestibular migraine / MDDS overlap. Whereas PPPD is the person is moving, or there's visual motion and they feel super dizzy and it doesn't go away particularly with more motion. That's more characteristic of PPPD, whereas something like Meniere's disease is going to be, they have attacks of vertigo and ringing in the ear, and that's the differentiation. And as I talked about in a Meniere's broadcast versus vestibular migraines, there's actually the ability now to do very high sensitive MRIs of the inner ear, 3 Tesla with gadolinium enhanced imaging, to see if there is actually swelling of the vestibular apparatus, because some Meniere's disease patients actually have vestibular migraines. So just the nuances. Now, let's go down. This is a really nice diagram of the motion sensitivity that a lot of PPPD patients experience. If you walk into a casino, for example, where they have the carpets laid out and there are a myriad of patterns on the ground and it makes you feel really dizzy, that can be synonymous with PPPD. Below is a nice diagram of a crosswalk, which looks like it's in a busy city. I have no idea where. And that visual motion creating dizziness is important. Let's see here. There we go. Now, I love this diagram because it really encompasses what PPPD patients experience and the risk factors for it. So they're saying predisposing factors: a neurotic personality, pre-existing anxiety disorder. Neurotic has kind of a pejorative connotation. Don't take it that way. But in essence, if you have a pre-existing anxiety disorder, that can be a predisposing factor for PPPD. Dizzying triggers. This is important for everybody to realize too, because vestibular crises are predisposing factors for PPPD. Because I treat a lot of patients who have vestibular migraines, and vestibular neuritis, and even BPPV and MDDS, they can go in and out of MDDS or vestibular migraines and PPPD. So keep that in mind. Lots of times they may start over here, and as they get better, they come over here. Why? Because those dizzying triggers or vestibular syndromes can then predispose a person for PPPD. So an important diagnostic feature to be aware of. Particularly, it affects treatment too. So vestibular crises, pre-syncopal attacks. So these are these individuals who almost faint. Think of your POTS patients, postural orthostatic tachycardia syndrome. So they get up and they get really dizzy, they have near faint dizziness. That can trigger a person into having PPPD, as well as things like panic attacks. Concussions can result in PPPD. So now they're saying, okay, so you have that dizzying trigger, and then you have high-risk postural control high risk. My toothpaste, I think, affects sometimes my saliva here for the morning broadcast. High risk postural control strategies, visual, somatosensory dependence, environmental vigilance. Particularly the second one, visual somatosensory dependence. So lots of times PPPD patients become very visually dependent. That's why when they see people walking through a crosswalk, they get really dizzy, or they walk into a casino and see the carpet, they get really dizzy, because their visual system is taking over for their vestibular system. And again, good balance is a symphony of your brain's ability to say, okay, what is my inner ear saying? What are my eyes saying? What is my neck? And what are my feet telling me? So I know where I'm at relative to my surroundings. If you're dizzy, there is an air signal typically in 1 or 3 of those symptoms, and or your brain's ability to compute those different signals. Okay, so then we have basically increased introspective self-monitoring. So if you are highly in tune with what's happening with your body, I commonly refer to this as introception, introspective introception. So if you're really introspective as to your symptoms, that can be a characteristic feature of PPPD. Top-down distortion of afferent signals, perception of dizziness and unsteadiness, high-risk postural control strategy. So basically, somebody who's very sensitive to what's going on with their body, and then they start to freeze up, they start to contract their muscles, they start to walk a little differently because they're less times afraid of falling, and they're afraid of the dizziness. Provoking factors can be upright posture, moving about, visual stimuli, as I discussed. And secondary effects can be neck stiffness, fear of falling, agoraphobia, not wanting to be around people, fatigue, dissociation, gait disorders. All those can be characteristics of PPPD. And again, vestibular syndromes can push someone into PPPD, and I have patients that go back and forth between their vestibular syndrome and PPPD. The treatment needs to be basically, focus on things like SSRIs, SNRIs, medical, natural, meaning get neurotransmitters correct in the brain to help with the anxiety component, as well as vestibular rehab, and if warranted, the individual may need cognitive behavioral therapy. And so that was kind of the main feature of it. So in summary, how are we doing on time? 7:53. Let me just look at any comments we have here. And good morning to everyone joining. Thank you so much. Thank you so much for the comments. Okay. So in summary, dizziness can be associated with anxiety. In essence, anxiety can be a predisposing factor for dizziness. In that setting, typically you're talking about something like PPPD, also referred to as PPPD, or Persistent Postural-Perceptual Dizziness. Also, vestibular syndromes can cause anxiety in and of themselves, and typically the vestibular syndromes that predispose to anxiety are vestibular migraines as well as Meniere's disease. Not as much BPPV or vestibular neuronitis. That's not always. I'm just saying in general. I have seen vestibular neuronitis patients that do develop anxiety and actually morph into a PPPD classification. But generally, vestibular migraines and Meniere's disease. Within vestibular migraines, you got to remember that the MDDS crowd, Mal-Day-Day-Barkman syndrome people, who've had recent boat, plane, or car ride travel that then develop this persistent rocking sensation, or sometimes it can be spontaneous, they fall into lots of times that vestibular migraine categorization. Go back and watch my videos on that. I'll probably do a video for it. So now we have vestibular syndromes predisposing to anxiety and depression, and then we also have to account for how you are manifesting today. So if your symptoms are more now, such that you are up and moving around and visual stimuli are making you more dizzy, now you're talking more about a PPPD categorization. But you have to understand how these two issues kind of ebb and flow and overlap. So I hope this helps. I hope this helps you to understand how dizziness and anxiety play off of one another. Again, maybe go back and watch our recent anxiety broadcast. To address anxiety in and of itself, you really want to focus on growing new brain cells in the memory area, because that memory area opposes the fear center. If we can oppose the fear center, we can change the way the brain talks to the anterior cingulate gyrus, which is a critical component right through here, critical component for depression and anxiety. When we can change those signals and then reduce anxiety, then lots of times we can help individuals with their dizziness, irregardless of the cause, if they're in PPPD or if they have something like a vestibular migraine or something like Meniere's disease. And again, what was a critical factor for patients with vestibular migraines and Meniere's disease to develop anxiety? It's that unexpected nature of it. It's the fact that I don't know what my day is going to look like. So I keep going back to releasing expectations as being an important factor for something like anxiety and depression. And that's where, in working with patients who have these disorders, I'm always trying to reiterate, you may have a bad day, but we can't let the bad days set us back or a bad week set us back. We have to look at the overall pattern. because looking at the overall pattern is critical for that individual making a long-term recovery. And I think the lack of, basically driving that point home is the reason why a lot of dizziness patients don't get better. And lots of times dizziness patients feel dejected. They feel pushed to the side because they go to the cardiologist and they're told that their heart is normal. They see the neurologist, says your brain is normal. They see the ENT and they say, okay, you have BPPV, or yeah, you do have vestibular migraines. Take these meds. They either work or they don't. If they don't work, then a person is kind of left feeling stuck and without a place to go. There is a place to go. You just have to have a more nuanced understanding of everything going on. So I think that pretty well summarizes it. I'm going to exit the live stream, and I hope this was helpful. Send me your comments. We'll be back tomorrow with another broadcast. We'll post that to social media, what we're talking about tomorrow. But I hope this was helpful, and I hope you all have a wonderful Tuesday, and we'll talk to you soon.